in this program. Especially so, addressing important issues like anemia and hypertensive disorders of pregnancy and diabetes, which is very much on rise. Having done with anemia and diabetes, now we are moving on to hypertensive disorders of pregnancy, and I heartily welcome you all for this learning process, which I think is one of the best means of educating ourselves. I was just interacting with Dr. Sangeeta Arya, and I was telling that even my postgraduate students are so enlightened and so benefited by this concept, and this understanding has enhanced in our approach towards the patient. I heartily welcome all the healthcare providers, all the facilities, all the doctors, consultants who have logged in today, and my heartiest welcome to Dr. Vidya Thobi, President of Kasuga, who has joined in, who has helped us to team up with the Safe Motherhood Committee of FOXY with Dr. Preeti Kumar, whose dedicated efforts, and with the team of wonderful Safe Motherhood Committee members, Dr. Nivedita Datta, Dr. Sangeeta Arya, Dr. Parul Gupta, who have all been committed in their services. I extend my welcome in absentia to all the leaders of FOXY who have helped us to conduct this program so successfully. Dr. Rishikesh Pai, Dr. Madhuri Patel, and the leaders in FOXY like Dr. Hema Divakar ma'am, and of course the Dian of patron of Kasuga, Dr. M.G. Hiramat sir, who was supposed to be here today. I each time would like to take their names because it's because of them that we are able to do our activities and take this meaningful, purposeful work ahead. I welcome Dr. Shobha Shavi, Dr. Shweta Kinivar, and the speakers and faculty for today, Dr. Sangeeta Arya, Dr. Vidya Chaudhary, and all who have logged in. And I hope that we have another interesting interaction today and with good take-home messages, because the prediction and prevention of hypertensive disorders of pregnancy is the most important challenging aspect, which will help to curtail the complications of hypertensive disorders for which we are afraid of. We know that this is one of the leading causes of death. And if we can achieve prediction and prevention successfully, then definitely the rate of HDP can be brought down from 10% to maybe even lesser. And that would be our final success if all of us implement this process actively. So the another topic is maternal and fetal complications of HDP. That is a later on, because after the pathology is set in, but our aim and attitude would be to curtail the pathology in the nib itself or in the bud itself. So this is how we are going about for a beautifully charted out program, well thought of, well implemented, and well being executed. Hearty welcome to you all and happy learning.
Thank you so much, ma'am. Thank you for your kind words. And yes, indeed, it seems to be very nice that everyone is benefited from this thing. And I would request our President Kasoga, Dr. Vidya Thobi ma'am, who is the professor and head of the department, Halamin Medical College, chairperson, food and drug and medical surgical equipment from 18 to 20. Best, she has got many awards in her name, and she has been a very eminent speaker in many national and international conferences. I would request Dr. Vidya Thobi ma'am to kindly give us her blessings.
Yes. Good afternoon to everyone, and it is really a pleasure to be a part of this district program. And I heartily again and again congratulate the Safe Motherhood Committee of FOXY as well as Safe Motherhood Committee of Kasoga. And I feel that including hypertensive disorders in pregnancy, which we thought of that it is one of the again major cause for the maternal morbidity and mortality, and including the various topics like prevention and prediction and the management, really is going to help all the healthcare workers, right from the checking of the blood pressure that has been taught in these modules. So I think it is going to be beneficial to all of us, as well as specifically the healthcare workers. I request all the healthcare workers, after the session is over, if they have any queries, please put on those queries here. So Sangeeta, really thank you very much, and I congratulate today's speakers who are taking a part in this. And our team is always ready to be associated with Safe Motherhood Committee of FOXY. I congratulate those who are taking part in this as well as in the assessment part. Thank you very much for inviting me. Thank you very much. Thank you.
Thank you so much, ma'am. Your blessings really count on us. Thank you so much, ma'am, for giving your valuable time. Now I would request Dr. Shobha, you will be saying some few words. Dr. Preeti, ma'am, as soon as she joins us, we will call her, or we should move to the sessions.
No, move to the session.
Dr. Nivedita will say.
Okay. Welcome, and it's indeed an honor to be with you all today. I'm very thankful to Kasoga team. I'm extremely thankful to Safe Motherhood Committee, especially Dr. Preeti, for this collaboration, which is going to, I think, have a great impact on the maternal and perinatal health in Karnataka. We've been hearing a lot about anemia. You've all been empowered about anemia. You've been enlightened about GDM. I would be very happy if I could get some bites from the doctors as well as from the nurses and the midwives about how this training has impacted their professional career, their academic empowerment, plus how has it affected the beneficiary. If each person can give some bite, by bite and in BYTE bite, on the WhatsApp group, we will be very thankful, because these are the things which count. If we know that we are making a difference, if we realize that these trainings are actually helpful and they are making a difference, this goes a long way in encouraging us to do more. Secondly, I would also be happy if you could share with us the detection rate of anemia, GDM, and the prediction of hypertensive disorders in your OPDs after, and how it has, how this training has created a difference in these 3 medical disorders. So if you could do that, that also would go a long way in letting us know that we have really been effective, that this training has been effective, both by we, I don't mean just Safe Motherhood Committee, I mean Kasoga Safe Motherhood Committee, as well as the FOXY Safe Motherhood Committee, as well as the whole of FOXY and the whole of the obstetric, all the obstetricians doing it, so that we know that these kind of trainings are effective. I thank you all, especially Dr. M.G. Hiramat sir from Kasoga, Dr. Kasturi, Dr. Vidya Thobit, President Kasoga, Dr. Rajeshri Paladi, the Secretary, Dr. Shobha Savi, our little darling Shobha, who's doing an immense work, all those facilities who have logged in, all the doctors who have agreed to participate, and all the health workers who are doing an immense job in this program. Thanks a lot. And over to you, Dr. Sangeeta, for continuing the rest of the program.
Thank you, Nivedita ma'am. Now we would like to move over to our sessions. For this session, I would request our first speaker, Dr. Parul Gupta ma'am. She is a senior consultant gynecologist at Lucknow and proud member of Safe Motherhood Committee. And I know her, she is very meticulous in everything. Over to you, Dr. Parul Gupta ma'am. She will be talking on prediction and prevention of preeclampsia. Dr. Parul ma'am.
Thank you, Dr. Sangeeta. Thank you for the kind words. And I really thank all the organizers for giving me this opportunity to talk on prediction and prevention of preeclampsia. I'll start sharing my screen and then is it full screen now?
No, it's yeah, yes.
Yeah.
So we are going to talk about prediction and prevention of preeclampsia, which is very important topic. We've already talked about anemia and gestational diabetes mellitus. हमने anemia के बारे में सीखा, gestational diabetes mellitus के बारे में सीखा, और अब हम ये जान जाएंगे कि ये तीनों टॉपिक्स कैसे इंटररिलेटेड हैं, क्योंकि जिसको एनीमिया है, जिसको जेस्टेशनल डायबिटीज मेलाइटस है, उसको हाइपरटेंशन भी होने की संभावना होती है. And in HDP, hypertensive disorders of pregnancy, we've already learned a lot about the diagnosis, classification, monitoring of blood pressure in the previous classes taken by Dr. Vidya and Dr. Veena. And they were wonderful classes. I think my talk is short, but very relevant. So why do we want to know about the prediction and prevention? We can just treat when it happens, when HDP happens, because hypertensive disorders of pregnancy is a cause of mortality, and it's the biggest cause of mortality and morbidity in the mother and the newborn. We have to predict, we have to prevent, and we have to treat preeclampsia if it occurs at an early stage, not when it happens. So I'll give you a short example. अगर किसी को twin pregnancy है और हमें मालूम है कि इसको डिलीवरी में ब्लीडिंग ज्यादा होने की संभावना है, तो उसमें हम सारे एडिक्वेट प्रिकॉशंस लेंगे. हमने प्रेडिक्ट कर दिया कि ऐसा हो सकता है, हम उसको प्रिवेंट करने की कोशिश करेंगे और उससे हमारी मोर्टेलिटी और मॉर्बिडिटी दोनों कम हो जाएंगी डिलीवरी के टाइम. इसी तरह से हाइपरटेंसिव डिसऑर्डर्स ऑफ प्रेगनेंसी के बारे में हमें जानना है कि हम उसको कैसे पहचान सकते हैं और कैसे उसको प्रिवेंट कर सकते हैं. तो प्रिडिक्शन, उसके बाद प्रिडिक्शन, उसके बाद प्रिवेंशन, प्रिवेंशन के बाद हम प्रीएक्लेम्सिया की चांसेस कम कर सकते हैं, एडिक्वेटली ट्रीट कर सकते हैं, एंड thus prevent the mortality and morbidity to the mother and fetus. Right? So again, as I said, early diagnosis is essential, not when it has already happened. हमें पहले से पता करना है किसको हो सकता है, उसको adequately पहले से treat करना शुरू करना है. तो इनमें prediction में दो चीजें important होती हैं. We have to take the history of the patient and we have to examine the patient thoroughly. There are so many points in history, not just the name, not just the weight and age of the patient and parity. The few risk factors are there which will come in the history, and then next will come the examination of the patient. Who should be screened for preeclampsia? आप सोचेंगे कि जो मोटा है, जिसको पहले से बीपी की परेशानी है, जो बहुत ज्यादा वेट गेन कर रहा है, उसको प्रीएक्लेम्सिया के लिए प्रेडिक्ट करना है, उसको स्क्रीन करना है? नहीं. We have to screen all patients who are coming to the antenatal clinic for preeclampsia, because firstly, preeclampsia can occur to anybody, not just an obese patient. It can occur to a thin patient also. And if we predict and prevent preeclampsia, we will obviously prevent the largest cause of mortality and morbidity in the mother and the fetus. So universal screening is recommended. All of the patients who are coming to antenatal clinic have to be screened, and then we pick up one out of maybe 50, maybe 30 patients who are prone to preeclampsia. So, but there are so many methods to predict preeclampsia, but there is still no single effective screening test. So we have to learn a lot about this prediction of preeclampsia, and we have to keep our mind open. So this could be right, this could be wrong. This is predicted in this beautiful slide. So can we predict if there is no single effective screening method? Still, can we predict? Yes, we can. By so many methods, we have around 80 to 85% positive prediction rate for preeclampsia. So we have to take a careful history in the early trimester. As soon as a patient comes to you, you have to take a very careful history and identify the mothers who are at risk very early in pregnancy. Dr. Gorakh Mandrupkar has developed a health HDP gestosis score, which can be done by any healthcare worker, may it be doctor, may it be a nurse, anybody can do this HDP gestosis score. It is very simple. You should put this chart in your OPD, and any healthcare worker can do it. HDP gestosis score. Gestosis basically means any abnormality in the placentation of the fetus to the mother. So when there is an abnormal milieu for the baby, then HDP, hypertensive disorders of pregnancy, can occur. There are so many pathophysiologies in this, but however, we have to just concentrate on the prediction risk factors. So HDP gestosis score is very effective and is truly positive in around 83% of cases. It involves all the existing, when the patient comes to you if she is pregnant, and the emerging risk factors in the pregnant woman. Because patient will keep on coming to you and you will identify more and more risk factors in these patients. So all the existing and the emerging risk factors in the pregnant woman. In HDP gestosis scoring, you have to give score 1 or 2 or 3 to any of the clinical risk factors as per its severity in the development of preeclampsia. You will give one score, only one means either 1 or 2 or 3 to each clinical risk factor. It is coming next. And when the total score is equal to or more than 3, pregnant woman should be marked as at risk for preeclampsia. Okay, got it? अगर कोई भी टोटल स्कोर 3 है या 3 से ऊपर है तो प्रेग्नेंट वुमन प्री-एक्लेम्सिया के रिस्क पे है. और प्री-एक्लेम्सिया के रिस्क पे हमने उसको आइडेंटिफाई करके क्या किया, उसको बहुत कुछ सिखाना है हमें कि आपको रेगुलर एंटीनेटल चेकअप्स के लिए आना है. आपका बीपी बढ़ सकता है कभी, तो आप बीच बीच में दिखाते रहो, जिससे कि ये ना हो कि आपका बीपी बढ़ जाए और आपको पता ना चले और आप सीधे एक्लेम्सिया में लैंड करो. और आपको क्या खाना है, कितना उचित खाना है और कैसे आपको एक्टिविटी रखनी है जिससे कि आपका वेट गेन ज्यादा ना हो, ये आप शुरू से उसको समझाना शुरू करोगे जो पेशेंट एट रिस्क फॉर प्री-एक्लेम्सिया है, जिससे कि हम लेटर इन वो प्रेगनेंसी बहुत जल्दी डिलीवरी ना कर दें, उसको अच्छे से टर्म तक ले जाएं और उसके बच्चे और उसको खुद को कोई परेशानी ना हो. अब इसमें 3 तरह के रिस्क फैक्टर्स होते हैं. आई विल शो यू 3 स्लाइड्स one after the other. Mild risk factors, which gives a score of 1. Then moderate risk factors, which gets a score of 2. And severe risk factors, which gets a score of 3. So mild risk factors में there are 7 risk factors, not 7, more than that. But if any 3 of that get a positive score of 1 each, then she's already at risk for preeclampsia. Understand this very well. Each factor gets a score of 1 if any of this is present. अगर पेशेंट की एज 19 से कम है और 35 से ज्यादा है, एक्सट्रीम्स ऑफ एज में वो प्रेग्नेंट हो रही है, तो उसको स्कोर 1 मिलेगा. ये माइल्ड रिस्क फैक्टर है, उसको स्कोर 1 मिलेगा, 1 मिलेगा. ठीक है, तो या तो 19 से कम है या 35 से ज्यादा है. इफ इट इज लेस देन 19 और मोर देन 35. जैसे मैंने शुरू में कहा, we will understand now why it is important to manage anemia, gestational diabetes, mellitus, etc. Now it comes. If the patient is anemic, she will again be more at risk for developing preeclampsia. So we have to properly treat the anemia if we catch her prior to pregnancy, or if she is coming to us and we have to treat her anemia, because it gets a score of 1. As soon as she is anemic, she will be more prone for hypertensive disorders of pregnancy. If her BMI is more than 30, obesity hai, again she gets a score of 1. So if patient has become pregnant for the first time, she gets a score of 1. And it is a very interesting fact that if patient has just got married, there is a very short duration of sperm exposure and very short duration of sex life, then also she gets a score of 1. So if she becomes pregnant for the first time, so score of 1. And if there is a very short duration of sperm exposure, again she gets a score of 1. If we know at what weight was she born, usually it is not known. But if somehow we can know what weight was a mother herself was born on. So woman born as small for gestation age will have a score of 1 for her future pregnancy also. It is a mild risk factor if she was born small for gestation age when she was born. So that is a very tricky situation. If there is a family history, anybody in the family, mother, father, or any blood relation has a heart disease or any vascular disease, again she gets a score of 1. If she is a patient of polycystic ovarian syndrome, which is very common nowadays, again she gets a score of 1. And if the inter-pregnancy interval, दो pregnancy के बीच में अगर 7 साल से ज्यादा का duration है, again it is a mild risk factor for HDP. So if she has conceived with IVF pregnancy, there will be another slide, so you have to understand this. If she has conceived with IVF pregnancy or ICSI pregnancy, she gets a score of 1. And there is another assisted reproductive treatment, which is known as ovum donor or surrogacy. There she gets a score of, we'll tell you later. So if the mean arterial pressure is more than 85, again she gets a score of 1. How do you calculate the mean arterial pressure? It is diastolic pressure plus 0.33 into systolic pressure minus diastolic pressure. It is, if you write it, it's very easy. Otherwise, you will think, kya ho gaya ye? Diastolic pressure plus 0.33 into systolic pressure minus diastolic pressure. So if the patient also has dyslipidemia and the cholesterol levels are haywire and she has chronic vascular disease, she again gets a score of 1. If there is excessive weight gain during pregnancy, as I've already mentioned just now, that we have to explain to patient how to eat, what to eat, how to do the activities, and how much activities have to be done in order to keep the weight at bay, not to increase excessively during pregnancy. Then also she gets a score of 1 if there is excessive weight gain during pregnancy. Usually 1 to 1.5 is allowed in the first trimester and 0.5 to 1 is allowed in the second and third trimester. But if there is more weight gain during pregnancy, she gets a score of 1. Now we come to moderate risk factors 2. In this, you have to understand if she is positive for 1 moderate risk factor and 1 mild risk factor, she is already at risk for preeclampsia. If she has 2 moderate risk factors, the score is 4, she is already at risk for preeclampsia. Okay. So if there is hypothyroidism in the mother, it is score 2. If there is a family history of preeclampsia, if anybody, any blood relation of herself has had preeclampsia, then the score is 2. If she has gestational diabetes mellitus, so in the previous slide I said in the existing and the developing diseases of pregnancy. So this is a developing diseases of pregnancy. If she is prone for gestational diabetes mellitus as seen by OGTT test, or if she develops diabetes later in pregnancy, she gets a score of 2 and she is now more prone for HDP as well. We were talking about obesity, more than 30 is score 1, more than 35 is score 2. More than 30 is score 1, more than 35 is score 2. Now we come to twin or triplet multi-fetal pregnancy. Again, she gets a score of 2. So multi-fetal pregnancy is a very good risk factor for everything, for gestational diabetes mellitus, for anemia, for HDP, and for everything, and for PPH as well. So if the patient has had a hypertensive disease during previous pregnancy, obviously she gets a score of 2 because there are chances of developing HDP again in the second pregnancy. Now, as you can see in the emoji, we are really scared about her, really worried about her. Now we come to the severe risk factors. The score is, if any of these, one of these is positive, अगर इनमें से एक भी पॉजिटिव है तो फिर आपको उसको लेबल करना पड़ेगा कि उसको प्री एक्लेम्सिया होने के, हाइपरटेंसिव डिसऑर्डर ऑफ प्रेगनेंसी होने के चांसेस पूरे हैं। अगर पेशेंट को जेस्टेशनल डायबिटीज मेलाइटिस है तो स्कोर 2 है। अगर पहले से उसको डायबिटीज मेलाइटिस है, प्री जेस्टेशनल डायबिटीज मेलाइटिस है, तो स्कोर 3। तो एकदम से आउटराइट वो हाइपरटेंसिव डिसऑर्डर्स ऑफ प्रेगनेंसी के लिए प्रोन हो जाती है। अगर अभी उसको पिछली प्रेगनेंसी में हाइपरटेंशन हुआ है तो score 2 है, but if she is now also hypertensive and hypertensive patient is becoming pregnant, the score is now 3. If patient has some mental disorders, the score is again 3. If she has, these are all complicated diseases thereafter, inherited or acquired. Sorry. If she has inherited or acquired thrombophilia, the score is 3. If she has chronic kidney disease, the score is 3. And if she has systemic lupus erythematosus and APLA or rheumatoid arthritis, autoimmune diseases like SLE, APLA and rheumatoid arthritis, the score is 3. Now we were talking about IVF pregnancy, the score was 1. But now if there is assisted reproduction with ovum donor or surrogacy, because now the mother is different. In ovum donor, the mother is different. We do not know. And in surrogacy, the mother is different. We do not know. So in these cases, we keep the score as 3 because there are more chances of developing hypertensive disorders of pregnancy. There are some other methods to predict hypertensive disorders of pregnancy. However, no screening test is really helpful. So various screening methods are, if you are doing an ultrasound and a Doppler, so if you see a diastolic notch at 24 weeks by Doppler ultrasonography in the uterine artery, this is a very good predictor out of all ultrasound parameters, Doppler parameters, this is the best. So if you see a diastolic notch at 24 weeks by Doppler ultrasonography, you can predict and keep a watch on hypertensive disorders of pregnancy. Also, if there is an absence or reversal of end diastolic flow in the umbilical artery, this is also a predictor of hypertensive disorders of pregnancy. So umbilical artery flow is either absent or reversed during end systole and indicates abnormally high placental resistance, reducing the blood supply to the fetus. So if the average mean arterial pressure, already told you, more than 85 or 90 in the second trimester, patient is prone for HTP. These are all the next test, which I'm going to tell you is in books only. We are not doing it, but some people are doing it. Infusion test is done. Angiotensin infusion required to raise the blood pressure more than 20 millimeter mercury from baseline is seen. And this can also be used. This is in experimental form. And rollover test is done. A rise in blood pressure more than 20 millimeter mercury from baseline or turning supine at 28 to 32 week gestation is positive. There is a rise in blood pressure more than 20 millimeter mercury from baseline. जब पेशेंट करवट से लेटी होती है और एकदम से सुपाइन होती है, सीधा होती है, 28 to 32 वीक्स पे अगर 20 मिलीमीटर मर्क्यूरी से ज्यादा उसका राइज हो रहा है तो फिर वो के लिए प्रोन है.
हेलो
ओके, सो कलर डॉपलर में हमें डायस्टोलिक नॉच देखना है यूट्राइन आर्टरी में और एब्सेंस और रिवर्सल ऑफ एंड डायस्टोलिक फ्लो देखना है अम्बिलिकल आर्टरी में. ये हमें मेनली याद रखने हैं. अच्छा, कुछ पैथोलॉजी के भी पैरामीटर्स होते हैं, बायोकेमिकल पैरामीटर्स होते हैं, but these above markers are good, but it can increase the predictive value also, but they are not cost effective at present and are not available everywhere. So these are for knowledge. These are vascular endothelial growth factor, VEGF. The second is soluble FMS like tyrosine kinase 1, placental growth factor, PIGF, and soluble endoglin and glycosylated fibronectin. So all these factors are available at some places. They're very costly. They're good predictors, but not cost effective for predicting HDP. Now we've done our prediction part. Now we come to what do we learn after prediction? We do the prevention. And then my next speaker will tell us about the treatment part. So what are the prevention strategies? We will take them one by one. Age of the woman, oral calcium supplements, folic acid supplementation. Obviously, we have to, if we catch the patient before she becomes pregnant, we have to start folic acid and continue it in the first trimester of pregnancy and in the second and third also. And weight of the pregnant woman is very important. As I've already told you, the BMI should be less than 30. When she gets pregnant, and the pre-existing diseases have to be treated, and aspirin has been used by many. So we will take them one by one. So age of the woman, we have to teach the patient, whoever is coming to us, because she might become pregnant some day or the other. So we have to teach each woman that you should not get pregnant in the extremes of ages. Avoid the extremes of ages. When you are below 19 or above 35, or just avoid the extremes of ages. It is a very important determinant of HDP. We have to treat the patient with calcium, and when we give full dose of calcium in a dose of 1000 milligram in divided doses, in the second and third trimester, not in the first trimester, we can prevent HDP, or at least prevent it from developing into pre-eclamptic toxemia if we give adequate amount of calcium, 1000 milligram in divided doses in the second and third trimester. So we have to be very vigilant that patient comes to us regularly, takes her tablets regularly, and gets her BP monitored as well. So weight of the pregnant woman, as you can see, if you can catch the patient again, if she's coming to you before she becomes pregnant, you have to teach her exercise and dieting and adequate diet so that her BMI comes around 25 or less than 25. And if she becomes pregnant at this stage, the chances of preeclampsia, even if she is at high risk for preeclampsia, the chances of preeclampsia getting severe is less as comparison to patients who are having a BMI of more than 30 or more than 35. So we have to strictly monitor the patient, not let her gain more weight than allowed, and do strict monitoring of whatever she is eating, and do adequate counseling so that she understands why does she need this counseling. Because she thinks she is pregnant, she has to eat for two. That is not the case. एक ही के लिए खाना है, अच्छा खाना है, हेल्दी खाना है, और धीरे धीरे आपका खाना बढ़ेगा. ये नहीं कि आप जैसे प्रेग्नेंट होते हो आप खाना पीना शुरू कर दो. ये नहीं होना चाहिए. So excessive weight gain is the earliest indicator of preeclampsia, and ideal BMI at the time of conception of pregnancy. So when the patient is coming to you pre-pregnancy, you have to counsel the patient that she has to become adequate, not thin, adequate at the time of conception. So all pre-existing diseases like just diabetes mellitus, chronic hypertension, or maybe it be SLE, etc., have to be treated prior to becoming pregnant and during pregnancy. Adequate visits have to take place to the doctor, to her doctor, and have to be told that she's pregnant now, and adequate precautions have to be taken. Otherwise, both her diseases, the preeclampsia and her already existing disease, may become severe in the third trimester of pregnancy mainly. Okay. And we use aspirin in some patients with high scores of prediction, so as to not to prevent preeclampsia, but to prevent the side effects which happen when preeclampsia occurs, when BP is raised, and all the placentation problems which are there in pregnancy. It can differ those problems in adequate doses. We can give aspirin in some patients. So now we move to the question and answer time, right? Ready? Quiz time?
आज का बनाए मेडिसिन का बनाए आप ओबीजी का बनाना.
So this is the first question. All of you unmute yourself. Unmute, please. So if the age is more than 35 and less than 19, she gets a gestosis score of. Please answer. Dr. Shobha, please help.
We don't have anything right now.
Dr. Shobha, please help.
ಹಲೋ
Yeah,
ಎಲ್ಲ
please.
ಅನ್ಮ್ಯೂಟ್ ಮಾಡ್ಕೊಳ್ಳಿ. ಅನ್ಮ್ಯೂಟ್ ಮಾಡ್ಕೊಂಡು ಇದು ಕ್ವೆಶ್ಚನ್ ಆನ್ಸರ್
Yes.
ಮಾಡಿ. Madam, there is a chat box.
Answer
One person has answered.
What
Yeah,
is the
yeah,
answer?
One,
We are
one.
getting answers. One. We are getting
Good,
answers of one.
good. Very good, very good, very good. So now this is the second question. If a patient becomes pregnant soon after marriage, it is a dash risk factor for HDP. Let's see. If a patient becomes pregnant soon after marriage, it is a dash risk factor for HDP.
We've got answers of mild.
Good. Very good. Multifetal pregnancy has a dash risk of having HDP. Let's see who has learned gestosis scoring. Multifetal pregnancy has a dash risk of having HDP.
0.3.
ಒಂದಕ್ಕಿಂತ ಹೆಚ್ಚಿಗೆ ಮಕ್ಕಳಿದ್ರೆ
Three severe.
ಅವ್ರಿಗೆ
Severe.
PH ಬರೋ ಚಾನ್ಸ್ ಹೆಚ್ಚಿಗೆ ಬರುತ್ತಾ ಕಮ್ಮಿ ಇರುತ್ತಾ?
What have they written?
0.33.
Severe.
They are
Severe.
writing
Severe.
The
Severe.
answer is moderate.
Moderate.
Moderate. Okay. And then the ideal calcium dose during pregnancy is, this is very easy.
1000 mg.
Very
Yes.
good.
Yes. Correct.
Rekha.
Correct.
1000 milligram per day in divided doses. And the last question is universal screening for preeclampsia recommended? Yes or no? Should we screen every patient? Yes. Somebody is saying yes.
Yes. Everybody has said yes.
Yes.
Meenakshi, Aarti.
Good. So we have a few take-home messages here. HDP is the most common medical problem in pregnancy. HDP affects the health of mother and baby both. So we have to treat the patient early. HDP is predictable with the help of HDP gestosis score, and proper and regular antenatal visits are must to detect it timely. Okay? This is the basic teaching. Proper and regular antenatal visits are must to detect it timely when we have predicted it. Okay? Thank you. Thank you.
Thank you, Parul ma'am. Thank you. We will have a repetition, ma'am. Kabhi they want revision of these classes. I think mild, moderate, and severe. So we can.
I'll share the slides. They can.
Madam, we'll cover it in mentoring classes, madam.
Yes, ma'am.
Because
Yes.
it is little difficult for them to understand.
Yes.
Because for GDM and anemia, we have given booklet. We have not given booklet for PIH. So that is one more reason they are finding it little difficult.
Yes, Dr. Sangeeta, Dr. Parul, ma'am, please you share your slides in the group today, and Dr. Shobha will arrange for mentoring after the classes get over.
I'm doing it just now.
Right. Thank you. Thank you.
Thank you, Parul ma'am. Thank you, Nivedita ma'am. Now we move forward for the next session. Our next speaker is Dr. Shweta Chinnanavar. She has done her MD from MMC Mysore, and she has done her fellowship in infertility from NUS Singapore. Currently, she is the director, Ashray Hospital, Bagalkot, Karnataka. She will be talking on maternal and fetal complications in hypertensive disorders in pregnancy. Over to you, Dr. Shweta.
Ma'am, thank you, ma'am. Actually, a little bit of difficulty in sharing the screen, ma'am. Like my PPT.
Okay, can you put on
No
the
problem, Shweta.
ಮ್ಯಾಮ್ ಅದು ಇದ್ರಲ್ಲಿ ಏನಾಗಿದೆ ಲ್ಯಾಪ್ಟಾಪ್ ಸ್ವಲ್ಪ ಇದಾಯ್ತು. ಈಗ ಮೊಬೈಲ್ ಅಲ್ಲೇನೆ ಶೇರ್ ಮಾಡಕ್ ಟ್ರೈ ಮಾಡ್ತಾ ಇದೀನಿ, ಇದು ಆಗ್ತಾ ಇಲ್ಲ ಮ್ಯಾಮ್ PPT.
Okay, if you can put it in the group, then I'll try to share it. Or you can send it to me, or you can send it to me on my personal mail. Even you can send it to the tech support. Who's the tech support? Arun.
Arun is there, but there is lot of weather problem in Hubli today. His internet is not very stable. He just messaged. Okay. Nandu.
Dr. Shweta, you can put it on the group. We will share. Nivedita,
Yeah, ma'am.
or yeah.
Yeah, ma'am. I'm just.
In the meantime, Dr. Shobha, you can ask for any doubts in prediction and prevention, and just ask people what they feel that how they are doing the prediction and what are the preventive measures. Till I download the video.
ಈಗ ಎಲ್ಲರೂ ಕ್ಲಾಸ್ ಕೇಳಿಸ್ಕೊಂಡಿದ್ದೀರಲ್ಲ, ನಿಮ್ಗೆ ಅರ್ಥ ಆಗಿದೆ ಅಲ್ವಾ? ಪ್ರೀ ಎಕ್ಲಾಂಪ್ಸಿಯಾ ಬರೋದನ್ನ ನಾವು ಹೇಗೆ ಮುಂಚೆನೆ ಪ್ರೆಡಿಕ್ಟ್ ಮಾಡಬಹುದು, ಮತ್ತೆ ಅದ್ರ ಬರ್ಲಾರ್ದಂಗೆ ನಾವು ಹೇಗೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡಬಹುದು ಅಂತ ಡಾಕ್ಟರ್ ಪಾರುಲ್ ಮೇಡಮ್ ನಿಮ್ಗೆ ಇವತ್ತು ಹೇಳ್ಕೊಟ್ಟಿದ್ದಾರೆ. ಸೊ ಇವಾಗ ಒಂದೆರಡು ಕ್ವೆಶನ್ಸ್ ಕೇಳ್ತೀನಿ, ಅದು ನಿಮ್ಗೆ ಅರ್ಥ ಆಗಿದ್ರೆ ಸರಿ, ಅರ್ಥ ಆಗಿಲ್ಲ ಅಂದ್ರೆ ನಾವು ಮತ್ತೊಮ್ಮೆ ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡ್ತೀವಿ. ಪ್ರಿಡಿಕ್ಷನ್ ಮಾಡ್ಬೇಕಂದ್ರೆ ರೆಡಿನಾ ಶ್ವೇತಾ?
ಕಳ್ಸಿದ್ದೀನಿ ಮ್ಯಾಮ್, ಕೋರ್ ವಿಸ್ತೃತ್ ಗ್ರೂಪಿಗೆ
ಕಳ್ಸಿದ್ದೀರಾ? ಓಕೆ 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 ಮೇಡಮ್, ಶೇರ್ಡ್ ಇನ್ ಕೋರ್ ವಿಸ್ತೃತ್. ಈಗ ಜೆಸ್ಟೋಸಿಸ್ ಸ್ಕೋರಿಂಗ್ ಅಂದ್ರೆ ನಿಮ್ಗೆ ಅರ್ಥ ಆಯ್ತಾ? ಏನೇನ್ ಪಾಯಿಂಟ್ಸ್ ಬರುತ್ತೆ ಜೆಸ್ಟೋಸಿಸ್ ಸ್ಕೋರಿಂಗ್ ಅಲ್ಲಿ ಗೊತ್ತಾ ನಿಮ್ಗೆ? ಕೇಳಿಸ್ಕೊಂಡಿದೀರಾ ಎಲ್ಲರೂ? ಜೆಸ್ಟೋಸಿಸ್ ಸ್ಕೋರಿಂಗ್ ಅನ್ಮ್ಯೂಟ್ ಮಾಡ್ಕೊಂಡು ಆನ್ಸರ್ ಮಾಡಿ. ಕೇಳಿಸ್ಕೊಂಡ್ರ ಇಲ್ಲ ನೀವು? ಗೊತ್ತಾಯ್ತೋ ಇಲ್ಲ? ಆಗ್ಲಿ ಒಂದು ಸಿಂಪಲ್ ಕ್ವೆಶನ್ ಕೇಳ್ತೀನಿ, ಆನ್ಸರ್ ಮಾಡಿ. ಈಗ ಸ್ಕೋರಿಂಗ್ ಮಾಡ್ತೀರಾ, ಸ್ಕೋರಿಂಗ್ ಜಾಸ್ತಿ ಬರುತ್ತೆ ಅಂತ ಪೇಷಂಟಿಗೆ ಯಾವ ಟ್ಯಾಬ್ಲೆಟ್ ನೀವು ಪ್ರಿಸ್ಕ್ರೈಬ್ ಮಾಡಬಹುದು? ಪ್ರೀ ಎಕ್ಲಾಂಪ್ಸಿಯಾ ಬರ್ಲಾರ್ದಂಗೆ ತಡಿಲಿಕ್ಕೆ ಯಾವ ಟ್ಯಾಬ್ಲೆಟ್ ನೀವು ಪ್ರಿಸ್ಕ್ರೈಬ್ ಮಾಡ್ಬೋದಂತ ಪೇಷಂಟಿಗೆ? Madam, nobody is answering today and they are finding it little difficult, I think.
No, I'm ready to screen share when you tell me to. Aspirin.
Aspirin ಯಾರು ಹೇಳಿದ್ದು? ಯಾರು ಆನ್ಸರ್ ಮಾಡಿದ್ದು ಆಸ್ಪಿರಿನ್ ಅಂತ? ಸಿಸ್ಟರ್ಸ್ ಡಾಕ್ಟರ್ಸ್? ಓಕೆ, ದಟ್ ಕರೆಕ್ಟ್ ರೇಖಾ. ಎಕೋಸ್ಪ್ರಿನ್ ಟ್ಯಾಬ್ಲೆಟ್ ನ ನಾವು ಶುರು ಮಾಡ್ತೀವಿ. ಯೂಶಲಿ 150 mg ಟ್ಯಾಬ್ಲೆಟ್ಸ್ ನ ಶುರು ಮಾಡ್ತೀವಿ. ಈಗ ನೆಕ್ಸ್ಟ್ ಕ್ಲಾಸ್ ಕೇಳಿಸ್ಕೊಳ್ಳಿ, ನಾವು ಸ್ಲೈಡ್ಸ್ ನ ಶೇರ್ ಮಾಡ್ತೀವಿ ಗ್ರೂಪ್ ಅಲ್ಲಿ, ಚೆನ್ನಾಗಿ ಓದ್ಕೊಳ್ಳಿ. ಮೆಂಟರಿಂಗ್ ಕ್ಲಾಸಸ್ ಅಲ್ಲಿ ನಾವು ಮತ್ತೊಮ್ಮೆ ಆನ್ಸರ್ ಮಾಡ್ತೀವಿ ನಿಮಗೆ. ಓಕೆ, ವೆರಿ ಗುಡ್ ಆರ್ತಿ.
Dr. Shweta, I think you can start.
Can I start now? Yeah, ma'am. Good afternoon, one and all. Thank you everyone for giving me this opportunity. Thank you, Safe Motherhood Committee. Today I'm going to speak on maternal as well as fetal complication in hypertensive disorder in pregnancy. ಅಂದ್ರೆ ಮೆಟರ್ನಲ್ಲು ಮತ್ತೆ ಫೀಟಲ್ಗೆ, ಮದರಿಗೆ ಮತ್ತೆ ಬೇಬಿಗೆ ಏನೇನ್ ಕಾಂಪ್ಲಿಕೇಶನ್ಸ್ ಆಗುತ್ತೆ ನಾವು ಟೈಮ್ಲಿ ಹೈಪರ್ ಟೆನ್ಷನ್ ಅನ್ನ ಡಯಾಗ್ನೋಸ್ ಮಾಡ್ಲಿಲ್ಲ ಅಂತ ಹೇಳಿದ್ರೆ, ಪ್ರಾಪರ್ ಎನ್ಸಿ ಮಾಡ್ಲಿಲ್ಲ ಅಂತ ಹೇಳಿದ್ರೆ, ಪ್ರಾಪರ್ಲಿ ಟೈಮ್ಲಿ ಇಂಟರ್ವೆನ್ಷನ್ ಮಾಡಿ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡ್ಲಿಲ್ಲ ಅಂತ ಹೇಳಿದ್ರೆ ಏನೇನೇನೇನ್ ಕಾನ್ಸಿಕ್ವೆನ್ಸಸ್ ಫೇಸ್ ಮಾಡ್ತಾರೆ ಮದರು ಮತ್ತೆ ಫೀಟಸ್ ಅಂದ್ರೆ ಬೇಬಿ. ಅದ್ರ ಬಗ್ಗೆ ಇವತ್ತಿಂದು ಟಾಪಿಕ್. ಸೊ ದ ವೆರಿ ಫಸ್ಟ್ ಮೆಟರ್ನಲ್ ಕಾಂಪ್ಲಿಕೇಶನ್ ಬಗ್ಗೆ ಮುಂಚೆ ಮಾತಾಡ್ತೀನಿ. ದ ನೆಕ್ಸ್ಟ್ ಟಾಪಿಕ್ ವಿಲ್ ಬಿ ಫೀಟಲ್ ಕಾಂಪ್ಲಿಕೇಶನ್. ಈ ಮೆಟರ್ನಲ್ ಕಾಂಪ್ಲಿಕೇಶನ್ ಅನ್ನ ನಾನು 3 ಗ್ರೂಪ್ಸ್ ಆಗಿ ಡಿವೈಡ್ ಮಾಡ್ಕೊಂಡಿದ್ದೀನಿ. ಒಂದು ಆಂಟಿನೇಟಲ್ ಕಾಂಪ್ಲಿಕೇಶನ್ಸ್, ಇನ್ನ ಒಂದು ಡ್ಯೂರಿಂಗ್ ಲೇಬರ್, ಆಮೇಲಿಂದ ಡ್ಯೂರಿಂಗ್ ದ ಪ್ಯೂರ್ಪೆರಮ್. So what are the antenatal complications? As you all know, antenatal complication anta ಹೇಳಿದ್ರೆ during pregnancy, untreated, undiagnosed hypertension ಅಲ್ಲಿ ಏನೇನ್ ಕಾಂಪ್ಲಿಕೇಶನ್ ಆ ಪ್ರೆಗ್ನೆಂಟ್ ಲೇಡಿ ಫೇಸ್ ಮಾಡ್ತಾರೆ ಅನ್ನೋದನ್ನ antenatal period during pregnancy. The common complication that we face is eclampsia, abruptio placenta, HELLP syndrome, cerebrovascular accidents, acute left ventricular failure, pulmonary edema, and microangiopathic hemolytic anemia. ಇದಿಷ್ಟು ಕಾಂಪ್ಲಿಕೇಶನ್ಸ್ ನಾವು ಆಂಟಿನೇಟಲ್ ಪೀರಿಯಡ್ ಅಲ್ಲಿ ನೋಡ್ತೀವಿ. ಸೊ ಡ್ಯೂರಿಂಗ್ ಲೇಬರ್ ಅಂದ್ರೆ ಡೆಲಿವರಿ ಟೈಮ್ ಅಲ್ಲಿ ಅನ್ಟ್ರೀಟೆಡ್ ಮದರಿಗೆ, ಹೈಪರ್ ಟೆನ್ಷನ್ ಇರೋ ಮದರ್ ಅಲ್ಲಿ ಏನೇನ್ ಕಾಂಪ್ಲಿಕೇಶನ್ ಫೇಸ್ ಮಾಡ್ತಾರೆ ಮದರ್ ಅಂದ್ರೆ ಎಕ್ಲಾಂಪ್ಸಿಯಾ, ಪೋಸ್ಟ್ ಪಾರ್ಟಮ್ ಹೆಮರೇಜ್, ಸೆರೆಬ್ರಲ್ ಹೆಮರೇಜ್, ಅಕ್ಯೂಟ್ ರೆಸ್ಪಿರೇಟರಿ ಡಿಸ್ಟ್ರೆಸ್ ಸಿಂಡ್ರೋಮ್, ಅದಾದ್ಮೇಲಿಂದ ಸರ್ಕ್ಯುಲೇಟರಿ ಕೊಲ್ಯಾಪ್ಸ್. ಸೊ ದ ವೆರಿ ನೆಕ್ಸ್ಟ್ ಇಸ್ ದ ಪ್ಯೂರ್ಪೆರಮ್. ಈಗೆಲ್ಲ ಅನ್ಇವೆಂಟ್ಫುಲ್ ಆಗಿ ಡೆಲಿವರಿ ಆಯ್ತು, ಹೈಪರ್ ಟೆನ್ಷನ್ ಇಂದ ಏನಾಗಿಲ್ಲ ಅಂದ್ರೆ ಅಷ್ಟೇ ಸೇಫ್ ಪೀರಿಯಡ್ ಇರೋದಿಲ್ಲ. ಡ್ಯೂರಿಂಗ್ ಪ್ಯೂರ್ಪೆರಮ್ ಅಂದ್ರೆ ಪೋಸ್ಟ್ ಡೆಲಿವರಿ ಹೈಪರ್ ಟೆನ್ಷನ್ ಇರೋ ಮದರಿಗೆ ಏನೇನ್ ಕಾಂಪ್ಲಿಕೇಶನ್ ಆಗುತ್ತೆ ಅಂದ್ರೆ eclampsia, patient may go for shock, they may also go for sepsis, and long-lasting neurological deficits like hemiplegia, visual disturbances, as well as dysphasia. So, idu maternal complications. In detail, and next further slides ಅಲ್ಲಿ ಮಾತಾಡ್ತೀನಿ. So, ಈಗ ಇಷ್ಟು ನಮಗೆ ಡ್ಯೂರಿಂಗ್ ಪ್ಯೂರ್ಪೆರಮ್, ಡ್ಯೂರಿಂಗ್ ಡೆಲಿವರಿ ಅಂಡ್ ಡ್ಯೂರಿಂಗ್ ಆಂಟಿನೇಟಲ್ ಪೀರಿಯಡ್ ಮದರ್ ಅಲ್ಲಿ ಏನೇನ್ ಕಾಂಪ್ಲಿಕೇಶನ್ಸ್ ಎಲ್ಲ ಆಗುತ್ತೆ ಅಂತ ಗೊತ್ತಾಗಿದೆ. ಸೊ ಇನ್ಸಿಡೆನ್ಸ್, ವಾಟ್ ಆರ್ ದ ಮೆಟರ್ನಲ್ ಕಾಂಪ್ಲಿಕೇಶನ್ ಇನ್ಸಿಡೆನ್ಸ್? ಇನ್ಸಿಡೆನ್ಸ್ ಅಂತ ಹೇಳಿದ್ರೆ ಒಂದು ಹೈಪರ್ ಟೆನ್ಷನ್ ಮದರ್ ಈಗ ಡಯಾಗ್ನೋಸ್ ಆಗಿ 100 ಅಲ್ಲಿ ಎಷ್ಟು % ಮದರ್ಗೆ ಏನೇನ್ ಕಾಂಪ್ಲಿಕೇಶನ್ ಆಗುತ್ತೆ ಅನ್ನೋದ್ರದ್ದು ಇನ್ಸಿಡೆನ್ಸ್ ಬಗ್ಗೆ ಹೇಳ್ತೀನಿ. Eclampsia. The eclampsia is seen in 2%. Placental abruption, it's in 10%. Neurological deficits is in 7%. Aspiration pneumonia 7%. Pulmonary edema 5%. Cardiovascular problems will be 4%. Acute renal failure is seen in 4%. And death is seen in 1% of the cases. So, going to the detail in the maternal complications. I'll be explaining one by one, not in detail illa anta helidrunu relevant agi enen irutte adanna explain ಮಾಡ್ಕೊಂಡು ಹೋಗ್ತೀನಿ. ಸೊ ಮೆಟರ್ನಲ್ ಕಾಂಪ್ಲಿಕೇಶನ್ಸ್, ಹೈಪರ್ ಟೆನ್ಷನ್ ನಾವು ಪ್ರಾಪರ್ ಆಗಿ ಟ್ರೀಟ್ ಮಾಡಿಲ್ಲ ಅಂತ ಏನೇನಿಕ್ಕಾಗತ್ತೆ ಅನ್ನೋದಕ್ಕೆ ಪೆಥೋಜೆನೆಸಿಸ್ ಪ್ರೀವಿಯಸ್ ಕ್ಲಾಸ್ ಅಲ್ಲಿ ಎಲ್ಲ ಮೆಂಟರ್ಸ್ ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡಿದ್ದಾರೆ. ಬಟ್ ಮೇನ್ ಹೈಪರ್ ಟೆನ್ಷನ್ ಗೆ ಥಿಯರೀಸ್ ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡುತ್ತೆ. ಮೇನ್ ಇಸ್ ಇದು ಅಬ್ನಾರ್ಮಲ್ ಪ್ಲಾಸೆಂಟೇಷನ್ ಆಗಿರ್ಬೋದು, ಇಮ್ಯುನಾಲಜಿಕಲ್ ಇಂಟಾಲರೆನ್ಸ್ ಆಗಿರಬಹುದು, ಅಥವಾ ಎಂಡೋಥೆಲಿಯಲ್ ಡಿಸ್ಫಂಕ್ಷನ್ ಅಂದ್ರೆ ಪ್ರಾಪರ್ ಆಗಿ ಒಟ್ಟು ಬೇಸಿಕ್ ಏನೇ ಕಾಂಪ್ಲಿಕೇಶನ್ ಆಯ್ತು ಅಥವಾ ಅನ್ಟ್ರೀಟೆಡ್ ಹೈಪರ್ ಟೆನ್ಷನ್ ಅಲ್ಲಿ ಮೇನ್ ಅದಕ್ಕೆ ಫೌಂಡೇಶನ್ ಏನಿರುತ್ತೆ ಅಂತ ಹೇಳಿದ್ರೆ ಪ್ಲಾಸೆಂಟಾಗೆ ಪ್ರಾಪರ್ ಆಗಿ ಫಂಕ್ಷನ್ ಆಗ್ತಿರಲ್ಲ. ಒಂದು ಪ್ಲಾಸೆಂಟಲ್ ವೆಸಲ್ಸ್ ಕೂಡ ಫಂಕ್ಷನಿಂಗ್ ಆಗ್ತಾ ಇರೋದಿಲ್ಲ. ಏನೇನ್ ಮಗುಗೆ ತಾಯಿಗೆ ಕರೆಕ್ಟ್ ಆಗಿ ಹೋಗ್ಬೇಕು, ಹೈಪರ್ ಟೆನ್ಷನ್ ಯಾವಾಗ ಕಂಟ್ರೋಲ್ ಆಗಿರೋದಿಲ್ಲ, ಆಗ ನಮ್ ಬಾಡಿಯಲ್ಲಿ ಏರುಪೇರು ಆಗಿ ಲಾಟ್ಸ್ ಆಫ್ ಕಾಂಪ್ಲಿಕೇಶನ್ ಆಗುತ್ತೆ ನಾವು ಪ್ರಾಪರ್ ಆಗಿ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಟ್ಟಿಲ್ಲ ಅಂದಾಗ. ಸೊ I'll be talking about the accidental hemorrhage. Accidental hemorrhage ಅನ್ನೋದಕ್ಕಿಂತ abruptio placenta in specific. Abruptio placenta ಅಂತ ಹೇಳಿದ್ರೆ 10% ನೋಡ್ತೀವಿ. ಸೊ ಪ್ಲಾಸೆಂಟಲ್ ಅಬ್ರಪ್ಷನ್ ಅಂತ ಹೇಳಿದ್ರೆ ಎನಿ ಬ್ಲೀಡಿಂಗ್, ಯಾವ್ದಾರ ಮಾಸು ಅಥವಾ ಕಸ ಅಂತ ಹೇಳ್ಬೋದು ಕನ್ನಡದಲ್ಲಿ, ಅಥವಾ ಪ್ಲಾಸೆಂಟಾದಿಂದ ಏನ್ ಬ್ಲೀಡಿಂಗ್ ಆಗುತ್ತೆ ಅದನ್ನ when the placenta is situated in the normal place, but when there is a bleeding from the placenta, that is called as placental abruption. ಈ ಪ್ಲಾಸೆಂಟಲ್ ಅಬ್ರಪ್ಷನ್ ಏನ್ ಅಷ್ಟು ಇಂಪಾರ್ಟೆನ್ಸ್ ಅಂತ ಹೇಳಿದ್ರೆ, ಈ ಒಂದು ಬ್ಲೀಡಿಂಗ್ ಮೇ ಬಿ ದೇರ್, ಇಟ್ ಇಸ್ ಅ ವೆರಿ ಡಿಸಾಸ್ಟ್ರಸ್ ಎಫೆಕ್ಟ್. ತುಂಬಾ ಗ್ರೇವ್ ಎಫೆಕ್ಟ್ಸ್ ಇದೆ ಮದರ್ಗೂ ಕೂಡ ಬೇಬಿಗೂ ಕೂಡ. ಸೊ ಬೇಸಿಕ್ ಫೌಂಡೇಶನ್ ಮತ್ತೆ ಇಂಟ್ರಾವ್ಯಾಸ್ಕ್ಯುಲರ್ ಕೋಯಾಗುಲೇಷನ್ ಡಿಫೆಕ್ಟ್ ಆಗುತ್ತೆ. ಯಾಕಾಗತ್ತೆ ಅಂತ ಹೇಳಿದ್ರೆ ಡ್ಯೂ ಟು ದ ಅನ್ಕಂಟ್ರೋಲ್ಡ್ ಹೈಪರ್ ಟೆನ್ಷನ್, ಮತ್ತೆ ಅದು ಪೆಥಾಲಜಿ ಬೇಸಿಕ್ ಆಗುತ್ತೆ. ಈ ಪ್ಲಾಸೆಂಟಲ್ ಅಬ್ರಪ್ಷನ್ಸ್ ಅಲ್ಲಿ 3 ತರ ಇರುತ್ತೆ. ಸೊ ಇಟ್ ಮೇ ಬಿ ಕನ್ಸೀವ್, ರಿವೀಲ್ ಅಂಡ್ ಮಿಕ್ಸ್ಡ್ ಮೆಜಾರಿಟಿ ಆಗಿ ನೋಡ್ತೀವಿ. ಬಟ್ ಹೆಂಗ್ ಬರ್ತಾರೆ ಈ ಪ್ಲಾಸೆಂಟಲ್ ಅಬ್ರಪ್ಷನ್, ಹೇಗ್ ಬರ್ತಾರೆ ಪೇಷಂಟು? ಸೊ ಏನಾಗುತ್ತೆ ಅಂತ ಹೇಳಿದ್ರೆ ದೇರ್ ಮೇ ಬಿ ಬ್ಲೀಡಿಂಗ್, ಅದ್ರಲ್ಲಿ ಗ್ರೇಡ್ 1, ಗ್ರೇಡ್ 2, ಗ್ರೇಡ್ 3 ಇರುತ್ತೆ. ಬಟ್ ಬೇಸಿಕ್ ಆಗಿ ನಾವ್ ಹೇಳ್ಬೇಕಂತ ಹೇಳಿದ್ರೆ ಎನಿ ಬ್ಲೀಡಿಂಗ್ ಫ್ರಮ್ ದ ಪ್ಲಾಸೆಂಟಲ್ ಸೈಡ್ ಇನ್ ಎ ಪೇಷಂಟ್ ಆಫ್ preeclampsia which has a disastrous effect on both mother and fetus. ಅದು ಮೇನ್ ಕಾಂಪ್ಲಿಕೇಶನ್ ಇರುತ್ತೆ. ಸೊ ದಿಸ್ ಇಸ್ ಅಬೌಟ್ ಪ್ಲಾಸೆಂಟಲ್ ಅಬ್ರಪ್ಷನ್. ಈ ಪ್ಲಾಸೆಂಟಲ್ ಅಬ್ರಪ್ಷನ್ ಅಲ್ಲಿ ನೆಕ್ಸ್ಟ್ DICನೂ ಆಗ್ಬೋದು, HUS, ಅದನ್ನ ನಾನು ಆಮೇಲೆ ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡ್ತೀನಿ. So hemolytic uremic syndrome, I'll just mention here. Hemolytic uremic syndrome is one of the component where it's a triad where the patient may have a renal failure ಹೋಗಿರ್ತಾರೆ, acute renal intervention, microangiopathic hemolytic anemia, ಆಮೇಲೆ thrombocytopenia ಅಂದ್ರೆ platelet count ಕಮ್ಮಿ ಇರುತ್ತೆ. So they may have ಈ blood vessels ಅಲ್ಲಿ ಕ್ಲಾಟ್ ಆದಾಗ ಏನೇನ್ ಸೈಡ್ ಎಫೆಕ್ಟ್ಸ್ ಆಗುತ್ತೆ, ಅದು hemolytic uremic syndrome. Entirely it's a different topic, but it is a complication of untreated preeclampsia. So next one is prematurity or preterm labor. ಈ prematurity iatrogenic ಅಂತಾನೆ ಇಲ್ಲದೆ ಇರ್ಬೋದು, ಬಟ್ ಡ್ಯೂ ಟು ದ ಇಂಡ್ಯೂಸ್ಡ್ ಮಾಡ್ಕೊಳ್ಬಹುದು, ಅಥವಾ ಈ ಅಬ್ರಪ್ಷನ್ ಇಂದನು ಆಸ್ ಎ ಕಾನ್ಸಿಕ್ವೆನ್ಸ್ ಆಫ್ ಅಬ್ರಪ್ಷೋ ಪ್ಲಾಸೆಂಟಾ ಕೂಡ patient may go for preterm delivery. It may be spontaneous. Preterm delivery ಅಂದ್ರೆ ಏನು? Any delivery which occurs before 37 completed week of pregnancy. So preterm delivery is also one of the complications. Though it has a less major effect on the mother, it has more effect on the fetus. So next complication, no? HELP syndrome. HELP is an acronym for hemolysis, elevated liver enzymes, and low platelet count. ಈ ಸಿಂಡ್ರೋಮ್ ಅನ್ನ ನಾವು ಯೂಶಲಿ 2/3 of the cases ನಾವು 3ನೇ ಟ್ರೈಮಿಸ್ಟರ್ ಅಲ್ಲಿ ನೋಡ್ತೀವಿ, ಅಂದ್ರೆ 6th, 7th, 8th, 9th ಮಂತ್ ಆಫ್ ದ ಪ್ರೆಗ್ನೆನ್ಸಿ ಅಲ್ಲಿ ನೋಡ್ತೀವಿ. ಹೇಗ್ ಬರ್ತಾರೆ ಈ ಪೇಷಂಟ್ ಈ ಹೆಲ್ಪ್ ಸಿಂಡ್ರೋಮ್ ಇರೋರು ಅಂತ ಹೇಳಿದ್ರೆ ರೆಸ್ಟ್ಲೆಸ್ನೆಸ್, ಅಜಿಟೇಷನ್ ಅಲ್ಲಿ ಬರ್ತಾರೆ. ಸೊ ಇಟ್ ಇಸ್ ಕ್ಲಿನಿಕಲಿ ನಾವು ಡಯಾಗ್ನೋಸ್ ಮಾಡಕ್ ಆಗ್ಲಿಲ್ಲ ಅಂದ್ರೂ ಲ್ಯಾಬ್ರೇಟರಿ ಇನ್ವೆಸ್ಟಿಗೇಷನ್. ಇಲ್ಲಿ ನಮ್ದು ಹೆಲ್ತ್ ಕೇರ್ ವರ್ಕರ್ಸ್ ರೋಲ್ ಏನಿರುತ್ತೆ, ಒಂದ್ಸಲ ಪೇಷಂಟ್ ಗೆ ತುಂಬಾ BP ಇದೆ ಅಂತ ಹೇಳಿ ಗೊತ್ತಾಗಿ ನಾವು ಕ್ಲಿನಿಕಲಿ ಅವ್ರದ್ದು ಹಿಸ್ಟ್ರಿ ತಗೊಳ್ಬೇಕಾದ್ರೆ ನಮ್ಗೊಂದು ಐಡಿಯಾ ಬರುತ್ತೆ. ಒನ್ಸ್ ವಿ ಇನ್ಫಾರ್ಮ್ ದ ಕನ್ಸಲ್ಟೆಂಟ್ ಅಂಡ್ ದ ಲ್ಯಾಬ್ ಇನ್ವೆಸ್ಟಿಗೇಷನ್ ಏನ್ ಮಾಡ್ತೀವಿ ಅದ್ರಲ್ಲಿ ದಿಸ್ ಇಸ್ ಡಯಾಗ್ನೋಸ್ಡ್. ಹೆಲ್ಪ್ ಸಿಂಡ್ರೋಮ್ ಇಸ್ ಆಲ್ಸೋ ಒನ್ ಆಫ್ ದ ಮೇಜರ್ ಕಾಂಪ್ಲಿಕೇಶನ್ ವಿಚ್ ಟ್ರೀಟೆಡ್ ಟೈಮ್ಲಿ we can save both mother as well as the fetus. Next complication, no? Eclampsia. Now during antenatal period, during labor, as well as during puerperal period, one common factor, one common complication ನೋಡಿರೋದು eclampsia. Eclampsia ಬರೀ 2% of the total deliveries ಅಲ್ಲಿ ನೋಡಿದ್ರು ಕೂಡ it has one of the major as well as a very deterrent effect on both mother and fetus. So ಏನ್ eclampsia ಅಂದ್ರೆ ಏನು? It's a development of convulsion or unexplained coma in a patient with the signs and symptoms of PE in the absence of any neurological disorder. ಅಂದ್ರೆ ಯಾವ ಪೇಷಂಟ್ಸ್ ಅಲ್ಲಿ BP ಇರ್ಬೋದು, BP ಜಾಸ್ತಿ ಇರ್ಬೋದು, ಅಥವಾ BP ನಾರ್ಮಲ್ ಇರುತ್ತೆ, ಅಂತ ಪೇಷಂಟ್ಸ್ ಅಲ್ಲಿ ಫಿಟ್ಸ್, ನಾವು ಫಿಟ್ಸ್ ಬಂತು BP ಇತ್ತು ಅಂತ ಹೆಂಗೆ ನಾರ್ಮಲ್ ಆಗಿ ಮಾತಾಡ್ತಾ ಇರ್ತೀವಲ್ಲ, ಆ ಫಿಟ್ಸ್ ಬರೋದ್ರಿಂದ ಏನಿರುತ್ತೆ ಡ್ಯೂರಿಂಗ್ ಪ್ರೆಗ್ನೆನ್ಸಿ ವಿತ್ ಪೇಷಂಟ್ ಆಫ್ ಹೈಪರ್ ಟೆನ್ಷನ್ ಅಲ್ಲಿ ಏನ್ ಕನ್ವರ್ಷನ್ಸ್ ಅಥವಾ ಫಿಟ್ಸ್ ಅಂತ ನಾವು ಲೋಕಲ್ ಲ್ಯಾಂಗ್ವೇಜ್ ಅಲ್ಲಿ ಯೂಸ್ ಮಾಡ್ತೀವಿ, ಅದನ್ನ ನಾವು ಎಕ್ಲಾಂಪ್ಸಿಯಾ ಅಂತ ಹೇಳ್ತೀವಿ. ಈ ಎಕ್ಲಾಂಪ್ಸಿಯಾ ಬರೋದಕ್ಕಿಂತ ಮುಂಚೆ ಏನಾದ್ರೂ ಸಿಂಪ್ಟಮ್ಸ್ ಇರುತ್ತಾ ಅಂದ್ರೆ ಹೌದು, ದ ಪೇಷಂಟ್ ಮೇ ಹ್ಯಾವ್ ರೆಸ್ಟ್ಲೆಸ್ನೆಸ್, ಹೆಡ್ಏಕ್ ಇರುತ್ತೆ, ಅಜಿಟೇಷನ್ ಇರುತ್ತೆ, ಎಪಿಗ್ಯಾಸ್ಟ್ರಿಕ್ ಪೇನ್ ಅಂತ ಬರ್ತಾರೆ, ಲಾಟ್ಸ್ ಆಫ್ ವಿಜುವಲ್ ಡಿಸ್ಟರ್ಬೆನ್ಸಸ್ ಇರುತ್ತೆ. ಸೊ ದಿಸ್ ಇಸ್ ದ ಒನ್ ವಿಚ್ ಹ್ಯಾಸ್ ಟು ಬಿ ಟ್ರೀಟೆಡ್ ಪ್ರಾಪರ್ಲಿ. ಸೊ eclampsia is seen in around 11 to 53%. So what is the next complication? No, as we all know, this preeclampsia is a multi-system disorder. Ad one system nu kuda bidodilla, ella system gunu minimum damage ಮಾಡಿರುತ್ತೆ. So what is this dimness of vision anta ಹೇಳಿದ್ರೆ, ಈ ರೆಟಿನಾ ಏನಿರುತ್ತೆ ಅದರಲ್ಲಿ ಒಂದ್ ಸ್ವಲ್ಪ ಕ್ಲಾಟ್ ತರ ಆದಾಗ patient may develop dimness of vision, they may go for even blindness. One good factor about this is that after the PE is treated, it's a self-resolving disease. Next complication is cerebrovascular accident, which is seen in around 7%. Cerebrovascular accidents during the preeclampsia anta ಹೇಳಿದ್ರೆ some major minor clot, cerebral hemorrhage ಆಗ್ಬೋದು, cerebral thrombosis ಆಗ್ಬೋದು, rupture intracranial aneurysms ಕೂಡ ಆಗ್ಬೋದು. Again the basic pathology ಏನಕ್ಕೆ ಇವೆಲ್ಲ ಆಗತ್ತೆ ಅಂತ ಹೇಳಿದ್ರೆ ಬ್ಲಡ್ ಕ್ಲಾಟ್ ಆಗೋಗುತ್ತೆ ಡ್ಯೂ ಟು ಡಿಫ್ರೆಂಟ್ ಥಿಯರೀಸ್. ಇದಾದಾಗ the patient may suffer these diseases. If treated properly, this all is preventable. Next complication is Neurological deficit. In neurological deficits is a long-term consequences of cerebrovascular accident. Commonly ನಾವು ಇದನ್ನ ಯೂಶುವಲ್ ಆಗಿ ನಾವು ಎಕ್ಲಾಂಪ್ಸಿಯಾ ಪೇಷಂಟ್ ಅಲ್ಲಿ ನೋಡ್ತೀವಿ. ತುಂಬಾ ದಿನ ಆದ್ಮೇಲೆ ಈಗ ಸೆರೆಬ್ರೋವ್ಯಾಸ್ಕುಲರ್ ಆಕ್ಸಿಡೆಂಟ್ ಆದಾಗ, ಬ್ಲೀಡಿಂಗ್, ಥ್ರೋಂಬೋಸಿಸ್ ಆದಾಗ ಲಾಂಗ್ ಟರ್ಮ್ ಸೈಡ್ ಎಫೆಕ್ಟ್ಸ್ ಏನಾಗುತ್ತೆ ಅಂತ ಹೇಳಿದ್ರೆ ದ ಪೇಷಂಟ್ ಮೇ ಹ್ಯಾವ್ ಎಮಿಪ್ಲೇಜಿಯಾ, ಆಮೇಲೆ ವಿಷುವಲ್ ಡಿಸ್ಟರ್ಬೆನ್ಸಸ್. Some patients may also have difficulty in talking, that is dysphasia. So next complication I want to talk about is acute respiratory distress. ಮುಂಚೆನೆ ಹೇಳ್ದಂಗೆ this is a multi-system disorder which is not going to spare any of the system. So respiratory system ಅಂದ್ರೆ lungs ಅಲ್ಲಿ ಏನ್ ಡ್ಯಾಮೇಜ್ ಮಾಡುತ್ತೆ ಅಂತ ಹೇಳಿದ್ರೆ the patient may go for acute respiratory distress. And the distress, as the name itself indicate, the patient may have hypoxia, ಉಸಿರಾಡ್ಲಿಕ್ಕೆ ತೊಂದರೆ ಆಗ್ಬೋದು. Sometimes worst of the worst consequences ಅಲ್ಲಿ the patient may even go for death. Next complication is aspiration pneumonia, commonly seen in a patient of eclampsia. Elli lungs ಒಳಗೆ ನೀರು ಹೋಗ್ಬಿಟ್ಟು it may damage the alveoli and may cause this pneumonia. The next complication is pulmonary edema, uncontrolled hypertension as a result of cardiac as well as lung. ಎರಡೂನು organ damage ಆದಾಗ pulmonary edema ಆಗುತ್ತೆ. It's a different topic, but it is a severe condition where timely intervention is very much needed. Then let us go for the cardiovascular problems. ಏನ್ cardiovascular, ಏನ್ ಹಾರ್ಟಿಗೆ ಏನೇನ್ ತೊಂದರೆ ಮಾಡುತ್ತೆ? BP ಇರೋ ಪೇಷಂಟ್ ಅಲ್ಲಿ, ಹೈಪರ್ ಟೆನ್ಷನ್ ಇರೋ ಪ್ರೆಗ್ನೆಂಟ್ ವುಮೆನ್ ಆಗ್ಲಿ, ಡೆಲಿವರಿ ಆಗಿರ್ಲಿ, ಬಟ್ ಹೈಪರ್ ಟೆನ್ಷನ್ ಅಲ್ಲಿ ಇರೋ ಪೇಷಂಟಿಗೆ, ಪ್ರೆಗ್ನೆಂಟ್ ವುಮೆನ್ ಗೆ ಏನೇನ್ ತೊಂದರೆ ಆಗುತ್ತೆ ಅಂತ ಹೇಳಿದ್ರೆ ದ ಪೇಷಂಟ್ ಮೇ ಗೋ ಫಾರ್ ಅಕ್ಯೂಟ್ ಲೆಫ್ಟ್ ವೆಂಟ್ರಿಕುಲರ್ ಫೇಲ್ಯೂರ್ ಆರ್ ಕಂಜೆಸ್ಟಿವ್ ಕಾರ್ಡಿಯಾಕ್ ಫೇಲ್ಯೂರ್. ಸೊ ಏನೇನಾಗುತ್ತೆ ಇದರಲ್ಲಿ ಅಂತ ಹೇಳಿದ್ರೆ ಪೇಷಂಟಿಗೆ ಉಸಿರಾಡ್ಲಿಕ್ಕೆ ತೊಂದರೆ ಆಗ್ಬೋದು, ಬ್ರೆತ್ಲೆಸ್ನೆಸ್ ಆಗ್ಬಹುದು. ದೀಸ್ ಆರ್ ಆಲ್ ದ ವೆರಿ ರಿಮೋಟ್ and contributes for about 4% of the incidence in a patient of PE. So acute renal failure, this is a very important complication because this is the one we notice very regularly. It is a component of hemolytic uremic syndrome allu irutte. Idralli enagutte anta helidre glomerular filtration rate, kidney functioning ge matte microangiopathic thrombosis agutte, kidney functioning decrease madutte. This may lead for the patient to go for oliguria matte anuria. Anuria andre complete shutdown where there is less than 100 ml of urine per day. Oliguria andre less than 400 to 500 ml in 24 hours. So this is the complication. The next complication, so oliguria and anuria. So as we all know, maternal complication in a patient of preeclampsia. So coming for the fetal complication, in mother-igantu, pregnant women-igantu, idu hypertension, untreated hypertension or the preeclampsia in a mother, if not treated, mother-ige ishtella complication ittu. ಈಗ ಮದರ್ ಅಫೆಕ್ಟ್ ಆಗಿದೆ, ಬೇಸಿಕ್ ಪೆಥಾಲಜಿ, ಬೇಸಿಕ್ ತೊಂದರೆ ಪ್ಲಾಸೆಂಟಾದಲ್ಲೇ ಇರೋದ್ರಿಂದ ಬೇಬಿನೂ ಏನು ಸ್ಪೇರ್ ಮಾಡೋದಿಲ್ಲ ಈ ಹೈಪರ್ ಟೆನ್ಷನ್. ಸೊ ಫೀಟಲ್ ಕಾಂಪ್ಲಿಕೇಶನ್ ಏನೇನಾಗುತ್ತೆ ಹೈಪರ್ ಟೆನ್ಷನ್ ಇರೋ ಮದರ್ ಅಲ್ಲಿ ಅಂತ ಹೇಳಿದ್ರೆ prematurity. Prematurity, as I defined prior, the prematurity, intrauterine growth restriction, intrauterine death, antepartum and intrapartum asphyxia, bronchopulmonary disease, neurodevelopmental disorder, and neonatal death. Prematurity. Prematurity, as I have told, any delivery that occurs before 37 completed weeks ಅಲ್ಲಿ ಏನ್ ಡೆಲಿವರಿ ಆಗುತ್ತೆ ಅದನ್ನು ಪ್ರೀಟರ್ಮ್ ಲೇಬರ್ ಅಂತೀವಿ. Any baby that is born before the time of delivery is premature. Premature ಅಂತ ಹೇಳಿದಾಗ ಮಗು ಸಣ್ಣದಾಗಿದ್ದಾಗ ಅದ್ರ ಡೇಸ್ ಕಂಪ್ಲೀಟ್ ಆಗಿಲ್ಲ ಅಂದಾಗ ಅದ್ರದ್ದೇ ರಿಸ್ಕ್ ಫ್ಯಾಕ್ಟರ್ಸ್ ಇರುತ್ತೆ ಬೇಬಿಗೆ. ಸೊ ವಾಟ್ ಆರ್ ದ ರಿಸ್ಕ್ ಫ್ಯಾಕ್ಟರ್ಸ್ ಇನ್ ಎ ಪ್ರೀಟರ್ಮ್ ಡೆಲಿವರಿ? ಪ್ರೀಟರ್ಮ್ ಮಗು ಹುಟ್ಟಿದಾಗ ಅದ್ರಲ್ಲಿ ಏನೇನ್ ತೊಂದರೆ ಆಗುತ್ತೆ ಅಂತ ನೆಕ್ಸ್ಟ್ ಸ್ಲೈಡ್ ಅಲ್ಲಿ ನಾನು ಹೇಳ್ತೀನಿ. ಸೊ the baby may have lung injury, brain injury, necrotizing enterocolitis ಆಗ್ಬೋದು, ಎಲ್ಲ ಆರ್ಗನ್ಗೂ ಹೈಲಿಂಗ್ ಮೆಂಬ್ರೇನ್ ಡಿಸೀಸ್ ಆಗ್ಬೋದು ಅದಕ್ಕೆ. ಸೊ ಮಲ್ಟಿ ಸಿಸ್ಟಮ್ ಆಗಿ ಅಫೆಕ್ಟ್ ಆಗುತ್ತೆ. ಇದು ಮದರ್ಗಷ್ಟೇನೆ ಬರ್ಡನ್ ಅಲ್ಲ, ಬೇಬಿಗೂ ಬರ್ಡನ್. ವರ್ಸ್ಟ್ ಆಫ್ ದ ವರ್ಸ್ಟ್ ಕೇಸಸ್ ಪ್ರೊಲಾಂಗ್ ಐಸಿಯು ಅಡ್ಮಿಷನ್ ಆಗುತ್ತೆ, ಅದ್ರದ್ದು ಕಾಗ್ನಿಟಿವ್ ಸ್ಕಿಲ್ಸ್ ಕಡಿಮೆ ಆಗುತ್ತೆ. ಸೊ ಪ್ರಿಮೆಚುರಿಟಿ has its own consequences. Again, this contributes for the uncontrolled hypertension or not treated properly. So next complication is intrauterine growth restriction. What is this intrauterine growth restriction? ಏನು IUGR ಅಂತ ಅಂದ್ರೆ ಎಲ್ಲಿ ಮಗು ಬರ್ತ್ ವೇಟ್ ಅಷ್ಟೇ ಕನ್ಸಿಡರ್ ಮಾಡೋದಿಲ್ಲ ಇದು. Even it may be less than 10% of the birth weight for that particular gestation ಇಲ್ಲ ಅಂತ ಹೇಳಿದ್ರು ಎಲ್ಲಿ ಆ ಮಗು ಅದ್ರ ಜೆನೆಟಿಕ್ ಪೊಟೆನ್ಶಿಯಲ್ ತಕ್ಕಂಗೆ ಅದ್ರದ್ದು ವೇಟ್ ಅದ್ರದ್ದು ಡೆವಲಪ್ಮೆಂಟ್ ಆಗುದಿಲ್ಲ ಅಂತ ಬೇಬಿನ ನಾವು ಇಂಟ್ರಾಯೂಟ್ರೈನ್ ಗ್ರೋತ್ ರೆಸ್ಟ್ರಿಕ್ಷನ್ ಅಂದ್ರೆ ರೆಸ್ಟ್ರಿಕ್ಟೆಡ್ ಗ್ರೋತ್ ಇರುತ್ತೆ. ಈಗ ನಾರ್ಮಲ್ ಆಗಿ ಹುಟ್ಟಿರೋ ಬೇಬಿ ಅಲ್ಲೇನೆ ನಾರ್ಮಲ್ ಆಗೇನೆ ಇರೋದಕ್ಕೇನೆ ಎಷ್ಟೊಂದು ಪ್ರಾಬ್ಲಮ್ ಇದ್ದಾಗ ಗ್ರೋತ್ ರಿಸ್ಟ್ರಿಕ್ಟೆಡ್ ಬೇಬಿ ಅಗೇನ್ ವಿಲ್ ಹ್ಯಾವ್ ಇಟ್ಸ್ ಓನ್ ಡಿಫಿಕಲ್ಟೀಸ್. ಸೊ ದಿಸ್ ಸ್ಲೈಡ್ಸ್ ಆಸ್ ಐ ಪ್ರಯರ್ ಡಿಸ್ಕಸ್ಡ್. IUGR ಏನಕ್ಕೆ ಆಗುತ್ತೆ ಈ ಬೇಬಿಲಿ ಅಂದ್ರೆ ದ ಒನ್ ಪ್ರೈಮ್ ಪ್ಯಾರಾಮೀಟರ್ ಅಂತ ಹೇಳಿದ್ರೆ IUGR ಗೆ ಅಂಡ್ ಡ್ಯೂರೇಷನ್ ಆಫ್ ದ ಹೈಪರ್ ಟೆನ್ಷನ್ ಅಂಡ್ ಪ್ರೋಟೀನ್ಯೂರಿಯಾ ಬಹಳ ಕಾಂಟ್ರಿಬ್ಯೂಟ್ ಮಾಡುತ್ತೆ ಇಂಟ್ರಾಯೂಟ್ರೈನ್ ಗ್ರೋತ್ ರೆಸ್ಟ್ರಿಕ್ಷನ್ ಗೆ. ಈ ಬೇಬಿಸಿಗೆ repeated infections, so failure to thrive, lots of admission, worst of the worst cases, they may go also for the death depending upon the etiology. Next complication. So this again, this oligohydramnios doesn't come under here. As a consequence of prolonged placenta in the neat iduk hogda irodrinda oligohydramnios agutte, adradu related agi the baby may go for IUGR. So next complication, these are the hematological changes that takes place. So ma'am, next slide, ma'am. Can I? So bronchopulmonary disease and the dysplasia, it is again contribute for the prematurity. Any development hyaline membrane neat age premature agi delivery adag enagutte inta babies alli respiratory functioning normal ಆಗಿ ಆಗ್ತಾ ಇರೋದಿಲ್ಲ ಅಂತ patient ಅಲ್ಲಿ they have a consequence of repeated respiratory tract infection, pneumonia, hyaline membrane diseases ಎಲ್ಲ ಇರುತ್ತೆ. So this is also one of the complication of the. So neurodevelopmental disorder. ಏನಿದು neurodevelopmental disorder ಅಂತ ಹೇಳಿದ್ರೆ preterm delivery as a consequences of preeclampsia patients ಅಲ್ಲಿ ಏನಾಗುತ್ತೆ mother baby born to the PE mother. ಈ babies ಅಲ್ಲಿ ಏನಾಗುತ್ತೆ ಅಂತ ಹೇಳಿದ್ರೆ owing for the IUGR as well as the prematurity, the patient may have, the baby will have as a result of the neurodevelopmental disorder ಅದ್ರದ್ದು IQ level ಕಡಿಮೆ ಆಗ್ಬೋದು, ಡೆವಲಪ್ಮೆಂಟ್ ಕಡಿಮೆ ಇರುತ್ತೆ, ಕಾಗ್ನಿಟಿವ್ ಸ್ಕಿಲ್ಸ್ ಕಡಿಮೆ ಆಗುತ್ತೆ. ಫಸ್ಟ್ ಆಫ್ ದ ವರ್ಸ್ಟ್ ಕೇಸಸ್ ಅಲ್ಲಿ ಲರ್ನಿಂಗ್ ಡಿಸಬಿಲಿಟೀಸ್ ಇರುತ್ತೆ. ಫಸ್ಟ್ ಆಫ್ ದ ವರ್ಸ್ಟ್ ಕೇಸಸ್ ಅಲ್ಲಿ ದ ಬೇಬಿ ಮೇ ಆಲ್ಸೋ ಗೋ ಫಾರ್ ಸೆರೆಬ್ರಲ್ ಪಾಲ್ಸಿ. ನೆಕ್ಸ್ಟ್, so fetal origin of adult diseases, the mother born to the baby of the pre-eclamptic mother will have a high risk of having the eclampsia. This is the fetal origin of the adult disease. So coming for the thing, this is about the maternal and fetal complications of the patient born with the hypertension. So what now I want to discuss is take home message enirutte anta helidre timely intervention is very much required for the prevention of this complication. So enen madbodu anta helidre regular ANCs, early diagnosis, counseling and health education not only of the mother but also the fetus. Early diagnosis and treatment will help us to prevent both maternal as well as fetal complication so that we can decrease the morbidity and mortality that is caused by the hypertensive disorders. So, thank you.
Thank you, Dr. Shweta.
Questions, ma'am?
I think the question should be asked by the healthcare workers, but I have one query. And that query is about the neurocognitive problems. Now, in severe preeclampsia or eclampsia, we are giving magnesium sulfate.
Yeah, ma'am.
And magnesium sulfate is decreases the incidence of neurocognitive disorders, or it is neuroprotective for a preterm infant. So would the incidence of, this is something which I always am wondering about, is would the incidence of neurocognitive disorders will be on par with a normal child, or would it be slightly decreased because of prematurity in a preeclamptic patient who has developed, who has been obviously given magnesium sulfate, or maybe a term preeclamptic or a eclamptic who has been given magnesium sulfate?
Ma'am, according to the journals and all, the p-value is less than 1 only, ma'am. Like both, but owing to the prematurity, it may be like spontaneous or untreated preeclamptic mothers, the risk is like more, ma'am. Otherwise, the p-value is less only, ma'am. It is neuroprotective only, ma'am. Journals.
Thank you. That's what I was always. Anyway, any questions? I think any questions? I don't see any questions in the group.
Dr.
I
Shweta.
would.
Yes,
I
ma'am.
would like to. I would like the people who have joined to just put on the chat box, out of all the complications that Dr. Shweta has mentioned, just put one complications which you remember. It could be maternal, it could be fetal. Just type in the chat box only one complication. So if today I have around about 32 participants, and maybe out of which 4 are faculty, I'm going to expect 28 responses about this, even if it is a yes, I've got one IUGR. Similarly, just keep putting in. It could be the same one, but please keep putting in. Thank you. Thanks a lot. I've got 2 IUD. Anything else? Just keep putting in any complication that you can remember from her talk. And she gave a very nice talk, very detailed talk. Yes, bronchopulmonary dysplasia. Yeah, but I've got the same from Jayashree. Jayashree, only one would do. Thank you. Anybody else? I've got Madhu Malati here, Rital Bhosle. Then I've got Minakshi, Sangeeta, Ganga, Divya Prakash, cerebral hemorrhage, oligohydramnios, fantastic. I get Bibijan, Ignesh, Sudha, Priyanka, Kanchan. I think we're getting in a lot of ones. I think we should give both the speakers a big round of applause. Great. So Dr. Shweta's talk has really, it's really made its mark. I can get we are getting answers in the chat box. Fantastic. Okay, over to you, Sangeeta.
Thank you, ma'am. Thank you. Now we here, if any other questions are there, we can take up in the next session also. Here we end circulatory collapse, they are also writing. Now we end up with this session on HDP, the second session. For this, I would like to thank our chairperson, Safe Motherhood Committee, Dr. Preeti Kumar ma'am, for her great vision and mission for making every motherhood safe through these kind of works, explaining and by learning of the healthcare workers, day-to-day learning of the main things, how can we save our mothers. Thank you so much, ma'am. Thank you for the office bearers of Foxy for giving us this opportunity, as well as I would like to thank our chief patron, Hiramat sir. We talked to him, he was busy somewhere else, otherwise he would have come. I also want to thank Dr. Vidya Thobi ma'am, the President Kasoga, Secretary Dr. Arshi Paladi ma'am. She is always there and she has given us good feedbacks that the classes are going very nicely. And Dr. Shobha Shavi, she is always there with us for the every kind of help. I would like to thank our speakers, Dr. Parul Gupta ma'am. She was not well today, but still she has very patiently and nicely explained everything, high risk factors and everything. And other speaker, Dr. Shweta, you have very nicely explained. We got the answers also. And I would request, I would thank our chair, Dr. Nivedita ma'am, for joining us today with this session and having all those support for us. And also to our listeners, our healthcare workers who have eagerly, nicely attended the classes and answered all the questions, as well as Dr. Vidya Chaudhary ma'am. As she was traveling, she could not join today. She has joined, but the connectivity problem is there. So she will be with us in the next session. Thank you, Dr. Vidya ma'am. and our technical support person, Mr. Arun, for giving us the platform to have this wonderful class. So thank you so much. Thank you everyone for joining this session.
Thank you, ma'am.
Thank you.
Shweta. Thank you, Parul ma'am. And thanks a lot, Shobha. And I know the mentoring will take place and Shobha will again go intensively into the whole thing, mentoring them. So we hope that we are going to have a great input with this also. Thank you, everyone. Thank you,
Thank
Jayashree. And
Thank
Aarti,
you, ma'am.
thank you. Jayashree and Aarti have the ones who have the maximum inputs in this class today. A special thanks to both of them. Love you both.
Bye, ma'am. Bye-bye.
Thank
Bye-bye.